I certainly appreciate the invitation to give this talk.
Sounds like John Dunning.
Yeah. That's weird.
I want to start actually just before I even do this, I'll tell you how I got interested in this field. I'm a neurologist. I'm not a psychiatrist. And when I first started my career, when I finished training and I moved up to Rhode Island, my primary research interest, which was in clinical neurology, had to do with the area of tardive dyskinesia, which many of you probably know about, some of you probably don't, which is a collection of movement disorders that are caused by drugs that are antipsychotic drugs used primarily to treat schizophrenia, sometimes bipolar disorder, sometimes major depressive disorders, but mostly schizophrenia. And all of the drugs used at that time for treating schizophrenics caused Parkinsonism, make people look like they have Parkinson's disease, and a variety of other types of disorders, including the tardive disorders. You probably have seen advertisements on television for some recently approved medications for treating the tardive disorders. And I was interested in that. And while I was working part-time at the only state psychiatric hospital in Rhode Island, I learned that they were going to participate in a trial of a new antipsychotic drug, which caused no Parkinsonism as a side effect. And it seemed to me that this was a terrific drug for Parkinson's disease patients, because most of my time I spent seeing patients not in the psychiatric hospital, but in my neurology practice, who had Parkinson's disease. And all of the medications that we have back then that we had, and also what we currently have for treating Parkinson's, may cause psychotic symptoms in people with Parkinson's disease who had no psychiatric history. So this seemed like an ideal drug for me. And there was a kind of perverse symmetry, in a sense, in the development of this drug, because all of the drugs for treating psychosis cause Parkinsonism, and all of the drugs we use for treating Parkinsonism might cause psychosis. And so because I treated a lot of patients with Parkinson's disease, I created, unfortunately, a lot of psychosis. And so it seemed to me that anything I could do to relieve the burden that I was partly responsible for in Parkinson's disease would be a great boon to the community. And in fact, the drug that was being investigated, a drug called clozapine, was in fact a terrific help for treating psychosis in Parkinson's, and remains to this day the best drug that we have for it. But it triggered my interest in, initially, the psychotic symptoms caused by medications for people with Parkinson's, which are very disturbing, which I will talk about among some other problems as well, and was very important for treatment. And it began a whole foray, I should say, into the study of behavioral problems in Parkinson's, and more generally, what we now call the non-motor symptoms of Parkinson's disease. So even though I am a neurologist, a movement disorder specialist, my special area of research interest has always been in behavioral aspects of Parkinson's disease, and the non-motor aspects of Parkinson's has attracted increasing amounts of interest for reasons that I will explain in just a few minutes. So I want to begin first with this email I got from a patient. Good evening, Dr. Friedman. I'm writing to inform you of some recent changes in my father's health, both physically and psychologically. He seems to be out of control. He is gambling every day, and yesterday we found out that he has dipped into his retirement funds for more money. He has nothing left, and no matter how many times we tell him and show him that he has no more money left, he doesn't comprehend. And that goes on. And here's the interview that I have with him and his daughter.
So first of all, I'd like to thank both of you for agreeing to this interview and for allowing me to show it.
There are no faces
in front of doctors and other health professionals. So first I'm going to start with your daughter to describe what she went through with this problem with the gambling, okay? And then I'm going to ask you to say a few words too.
My father's had Parkinson for over 10 years. At the beginning, we were finding that he was spending unnecessary money. It has led to us taking over his finances. He has totally wiped out his life earnings, which was over $250,000, with visa bills over $25,000 had to be repaid. Now he's only allowed so much money per week. And with this, as soon as he gets money in his possession, he will spend it on things, like food and everything, but he will also lie and spend it on scratch tickets, which he claims is not a form of gambling. It's just a few tickets. And when asked about his life savings, he will say that he doesn't cry over spilled milk. And just yesterday, he said that he took $25 out of the bank. I asked him what it was for. He told me it was for dry cleaning. I asked him, where he has his help, what the $25 was for. Did he pick up dry cleaning? He knew nothing about that. And then my father admitted that he spent the $20 on scratch tickets. So this is just one of the thousands of examples how he continues to lie about how he uses the money that we give him and allow to him.
And he didn't have a gambling problem before the Parkinson.
Absolutely not. In fact, when he used to go to Atlantic City a few times with our mother, he used to get angry when my mother used to play the nickel machine. And then he became a few games of baseball, but that was like a neighborhood pool for us. But it was never, ever as much as bad as this.
Thank you. And what's your take on this?
Well, I must admit that the whole process started with the money.
Yeah.
Gambling habits. Attractive.
And what do you see? How do you see it now? I mean, your daughter says it's still happening.
Well, not gambling that much. I had to buy a scratch ticket. I can play lottery. Winning like $100 million.
Do you think she's exaggerating?
She's exaggerating.
But you did lose all your life savings, right?
It wasn't $200.
But it was a lot of money.
$125.
But you lost that.
I lost that.
Okay. So that's still a lot of money, right?
Very sorry I lost that.
Sure.
And,
but what about the $25 you spent yesterday?
$25 I spent yesterday. I spent $15. I bought into Chubby's shop, fish and chips.
No, what about the scratch tickets?
I bought a couple of scratch tickets.
So but you don't see that as a problem?
I don't see that as a problem.
Okay. Thank you very much. So first of all,
So that's just an introduction. This can be a very major problem. This is something you may have read about as a potential side effect of dopamine agonist drugs like pramipexole and lopinirol, and the rotigotine patch, which occurs in about 10 to 15% of patients. But it brings up an example of the kind of problems that we see in Parkinson's, or actually that we didn't see in Parkinson's, even for over 20 years after some of those drugs were released on the market, because who would have thought of a drug side effect being gambling, for example? I mean, it's not something that would occur to somebody. And so there are potentially behavioral problems that are occurring now that we don't recognize either. And here's a statement I came on. Obviously, Plato lived a couple thousand years ago, but even then, he said, "For this is the great error of our day in the treatment of the human body, that physicians separate the soul from the body." By soul, he didn't mean, say, a religious sort of soul, but soul meaning what sort of traits people have that define them as unique from other people, what sort of problems they have, what their interests are, what their loves are, things like that. And basically he was talking about the importance of other things than just what we see on the surface. So as you know, or maybe as you don't, but Parkinson's disease is defined clinically by motor features. So we look for slowness of movement, reduction in spontaneous movements. We look for the tremor, of course. We look for stiffness, which we call rigidity. We look for a change in posture. We look for how people walk. And that's the clinical definition. There are clinical criteria for diagnosing, for making the diagnosis of Parkinson's disease. There's no laboratory test that says this person has Parkinson's disease other than an autopsy. So we never know 100% for sure that a person who is alive actually has Parkinson's disease. And while it's defined by these motor features, the rigidity, the slowness, the stiffness, and the tremor, there are non-motor signs and symptoms that also occur. And I've divided the non-motor symptoms into two broad categories. One is the behavioral category, which I'll go in more detail about, and the other is the somatic or bodily functions, different than behavior, but not part of the motor symptoms, the movement symptoms. We use the term motor and movement interchangeably. So the autonomic symptoms, most of you probably have one of these or more. The autonomic symptoms include changes in bladder control with overactive bladder as a common problem for both men and women. Constipation, which, as you know, is a very common problem in older people in general, but particularly in Parkinson's disease. There are some cardiac changes which are luckily subclinical, so they're not of any clinical importance, but which can be demonstrated in the majority of Parkinson patients. And there is a problem which can be very difficult to treat, which is called orthostatic hypotension. Orthostatic meaning standing up, and hypotension meaning low blood pressure, unlike high blood pressure, which is hypertension. So changes in blood pressure control, in constipation, your bowel motility, in bladder control are all autonomic symptoms, and these are very common in people with Parkinson's. There also is a common problem that very few people actually know about called rhinorrhea or runny nose, having clear fluid come out of the nose throughout the day, throughout the year, unrelated to seasonal allergies, is a fairly common problem in people with Parkinson's disease and very rarely recognized as being a problem. And it's not generally a major problem. It's just a mildly annoying problem. There are changes in respiratory function, which are very poorly defined and have not been investigated adequately. And there are some patients with Parkinson's, luckily pretty rare, but does occur, where people have problems with sweating control, and they will tend to sweat excessively, usually in some very often related to their medication. Pain is a very common problem in Parkinson's disease. In studies that have been published, people with Parkinson's complain of pain about twice as much as people their age who don't have Parkinson's disease. People with Parkinson's also have an impaired sense of smell. That can be demonstrated with formal testing of smell in the majority of people with Parkinson's, even at the time they're first diagnosed. And then there are skin changes that are quite common. The skin may become somewhat greasy over the forehead and the cheeks and the scalp, causing dandruff or some scaling of the skin, particularly in those areas. And then, of course, the behavioral, which is what I'm going to focus on. So this is a study from China, but it's been replicated throughout the world in all parts of the world, all cultures. The clinical factors that showed the highest predictive values for worse health-related quality of life were non-motor symptoms, such as depression, sleep disorders, and fatigue. In other words, these three types of problems were more challenging, caused more problems for Parkinson's disease in general than the motor symptoms by which we define the disease. So I think that although we consider Parkinson's disease a movement disorder, and I'm a movement disorders neurologist, Parkinson's disease is probably best considered as a neurobehavioral disorder because the problems with behavior are so common and often dwarf the motor features of the disease. Now, this slide has a lot of things on it. I've divided the behavioral problems in Parkinson's into two broad categories as well. Those that are intrinsic to the disease, by which I mean those are problems that we believe are caused by the loss of brain cells in particular regions of the brain, and as a result of the loss of those brain cells, whether it's from Parkinson's disease or some other disorder, people get this sort of problem. And then there are the iatrogenic. Iatrogenic means it's a problem caused by the treatment of Parkinson's disease. And in most cases, these side effects cannot be avoided unless you don't use the drug. So there are iatrogenic complications caused by the medications we use, and that's the major form of iatrogenesis. And then, of course, there are people who will have deep brain stimulation or focused ultrasound treatment. And in that case, those may cause their own problems in behavior. So let me run through these quickly, and I'll focus more on some than others. You're probably all aware that depression is a very common problem in Parkinson's disease. And it affects somewhere between 30 and 50% of patients, but that depends on definitions that you use. It can be very difficult to define what depression is in Parkinson's disease. In the general population, there are criteria that are used for defining depression, but many of those actually are part of Parkinson's disease. So people with depression often suffer from sleep disorders, but sleep is a common problem for people with Parkinson's. People who are depressed often have a soft voice. Well, that's common in Parkinson's disease. People with depression often have fatigue, but that's common in Parkinson's disease. And of course, people with Parkinson's often have difficulty enjoying their lives because things that gave them pleasure, they may no longer be able to do because of motor impairments. But in fact, a group that was convened by the National Institutes of Health many years ago, maybe about 15 years ago, tried to define depression and Parkinson's disease, and basically they came out with the decision that probably if a person with Parkinson's feels depressed, they feel sad, they feel blue, that means they're depressed. And I think, although that sounds kind of silly as a common sense approach, I think it's actually a good solution to the problem rather than defining it by having a certain number of characteristics. Apathy is a problem in Parkinson's that I'll get to later, and is a very difficult and common problem that often is thought, interpreted as depression when in fact is not. Dementia is the worst of the behavioral problems because dementia by itself causes problems, namely problems with memory, problems with thinking, with problem solving, with planning. But in addition to that, people who suffer from dementia are much more sensitive to the drug behavioral side effects, the behavioral side effects of the drugs that we use for treating Parkinson's disease. So the dementia itself often limits how aggressively we can treat motor problems in Parkinson's, because when we use these drugs, they often cause side effects like hallucinations or the gambling or something else like that. Anxiety is common in Parkinson's, and it's been very poorly studied. In fact, even though anxiety affects between 30 and 50% of people with Parkinson's disease, there have been no double-blind, placebo-controlled trials to treat anxiety. Fatigue is common. Fatigue affects 30 to 50% of Parkinson's disease patients as their most bothersome symptom. A number of sleep disorders occur in Parkinson's disease, some of which are really quite interesting, something called REM sleep behavior disorder. There are people who believe that there is a change in personality that occurs with the development of Parkinson's disease as part of the disease itself. Occasionally, there are people who feel very restless with Parkinson's. We call that akathisia. And then there's a group of what I call misperceptions in Parkinson's disease, where people with Parkinson's don't perceive their environment exactly the way other people do. The iatrogenic ones, the ones that are caused by treatment, include the psychotic symptoms like hallucinations, confusion, fluctuating level of consciousness that we call delirium, psychosis, which is a loss of reality testing, thinking things are going on that really are not going on. There are the compulsive behavior disorders, the gambling one I showed you the video of, that includes gambling as the most common, but hypersexuality is the second or third most common. People will do things over and over again that they can't stop, but which seem to them to be quite normal and appropriate. But somebody might start, for example, playing computer games and just play computer games all day long and not go to sleep at night because they can't stop playing the game. And then there are iatrogenic problems caused by medications that affect sleep. Levodopa in particular, which most of you are taking now, frequently causes vivid dreams, that is, very realistic dreams. Dreams so real that when people wake up in the morning, they will ask somebody else about their dream because they think it actually took place. And that, of course, induces a certain amount of concern among the family who think that the person now is hallucinating or they're psychotic or they're confused, but in fact, they're simply asking about what happened in their dream. So some of you have heard of a condition called Lewy body dementia or dementia with Lewy bodies, and that is really a form of Parkinson's disease, or at least I believe it is. There is argument in the field, and there are people who disagree with that. But the pathology, the changes that occur in the brain are similar. The major difference between dementia with Lewy bodies and Parkinson's disease, when people with Parkinson's develop some memory and thinking problems, is that in dementia with Lewy bodies, the memory and thinking problems develop before the Parkinson's disease or within 12 months of the motor features. And the hallucinations occur before patients are put on medicine. With Parkinson's disease, the hallucinations almost only, 90 to 99% of the time, they occur only in patients who are started taking medication. So I'm going to talk a little bit about psychotic symptoms. So psychotic symptoms are those that are different than reality. A person experiences a difference in reality. And they occur primarily in people who are taking medications. They often occur in people who are in delirium. So you get a urinary tract infection, you get pneumonia, you get bronchitis, you get the flu. Probably if you get COVID, you may start hallucinating, and then when the viral infection passes or the bacterial infection passes, it goes away. And then, of course, people with psychotic symptoms, because they have a primary psychiatric disorder, may develop Parkinson's disease. Hallucinations are far and away the most common problem that we see, psychotic symptoms that we see as a result of drug treatment of Parkinson's disease. Medications that we use may induce hallucinations in 20 to 30% of patients. So it's very common. It can be very scary to patients, not that the hallucinations are scary, but just that the fact that the mind is playing tricks on them often is upsetting. I think that would be true for anybody. A hallucination is something that a person perceives in one of their special senses. So the special senses are vision, hearing, touch, smell, and taste. In addition, people with Parkinson's frequently have this problem that is called presence hallucinations. They're not really hallucinations, but a patient has a strong feeling that there's someone else in the room with them, or something else like an animal. It's never perceived as threatening. It's mostly that they just think there's someone in the room with them and they turn around and look and there's nobody there. So I want to have just 3 little interviews of patients describing their hallucinations. And of course, it won't work to them, even though it worked for me before. Next one. Okay.
Take your permission with Dr. Friedman to show my videos to other health professionals and also to patients. Negative. Can you describe hallucinations? Can you see they start out as like little angels playing around. When I look out the window, I see the angels, and sometimes they'll be playing for a couple of hours maybe, and then they go on. Then other times there's actually other things that hallucination is. Bigger, almost like people, but they don't have any faces. They're just there. Are they scary at all? No. Any angels, do they have faces? No, they don't. None of them are scary. None of them are scary. No, they interact with you at all? No, not at all. So they ignore you. Yeah, it's almost like they're there and they're not there. They're there and not there. If you read that to me. Okay. Okay, read away, please.
I give permission for Dr. Friedman to show my video to other health professionals.
Thank you very much. Can you describe the hallucinations?
Hallucinations that I've been having are usually tied to a small group of people who I identify as part of a hallucination because of some characteristics I'm aware of. For example, I realized that you can't communicate with, I had to hallucinate that someone was part of a hallucination. That's a thing. I identify with.
What do they?
They appear to be Homo sapiens. They are.
Wait, they look like normal people?
No, they don't look like normal people. If you were to say, well, how big is that guy's nose? It's something that isn't specific enough for whatever's going on. So I have an hallucination, and I look at where the face of that person, whatever it is, I pursue it sometimes, and other times not, but always just something that appears like hints at being.
But before you said you saw people who looked like people who you knew that you couldn't recall their names.
Well, I'm not particularly remembering.
Are they in color?
Yes.
Do they talk to you at all? Make noise? Do they interact with you?
And Dr. Friedman, could you repeat a little of what he's saying? People were saying in
Yes.
the chat that it was hard to hear. Thank you.
Okay. So I understand that what he was saying is hard to hear. So the first person was talking about seeing angels. And he saw angels, but only in one window in his bedroom, not in the other windows. And he didn't see their faces, and they played for about 2 hours at a time, and they ignored him completely. This man is seeing people as well, but they don't have faces, and yet it's not disturbing. Then he said that they did have faces, but the nose on at least one person was not a normal nose. And that's not uncommon either. And in both cases, he reports that the hallucinations pay no attention to him, and that's typical. So a person is seeing something going on. They're seeing people, they see adults, they often see children, and when they try to interact with the hallucinations ignore them. And the typical response then is the person gets up from the chair. If they're at home, they go over to the hallucination, and the hallucination disappears. So the first one, I'm sorry, it didn't run, and that's my technical fault. My favorite story of a hallucination, because I like to listen to what these are, and they're all fairly similar, but there are variations. And one patient told me that when I asked him, do you have hallucinations? He said, yeah. I said, well, what do you see? He said, I see people outside. So I asked, how do you know it's a hallucination if they're outside? He said, well, every morning when I sit to eat breakfast, this group of nuns wearing habits comes over and starts building me a deck. So I agreed that that was a hallucination, since that would not occur in real life, but it was an interesting thing. And patients sometimes enjoy their hallucinations. I had a man who saw a baby every night, and he smiled and said the baby was so good because he never made any noise. But people can also hear things. They can have auditory hallucinations. They can have tactile hallucinations where they feel things crawling on their skin. They can have smell hallucinations. They can have taste hallucinations. But those tend to be rare. In primary schizophrenia, patients typically have auditory hallucinations, and the hallucinations that they have almost always have some emotional content which is negative. The voices are telling them bad things, how people hate them, how they're dying of cancer, how they're rotting on the inside. Whereas people with the hallucinations in Parkinson's disease generally see things, and they see, people playing in trees. They see people sitting on the sofa watching television with them. They see kids playing cards in the living room. They see cats or dogs running around, but they're not scary dogs. They're not bothersome. On the other hand, the hallucinations can be bothersome. They're usually not threatening in the sense of somebody holding a gun to your head. But if you wake up at 2 in the morning to go to the bathroom and you see a strange man standing at the foot of your bed, that's very disconcerting. And if you see 3 people in your bathroom, that is also disconcerting. And if you see a lot of people who are strangers going in and out of your house, that can be very upsetting as well. And people will call the police in order to get these intruders out of their house. When people report things like hallucinations, there are other possible explanations. It might be vivid dreams, as I mentioned before. Sometimes people have hallucinations when they're first falling asleep or waking up that really don't have much to do with the medications they take, but they only last several seconds, maybe a minute. And patients may talk and interact with the hallucination. Depression, as I mentioned, affects about 30 to 50% of patients. It's frequently associated with anxiety. And some people think the depression in Parkinson's disease is somewhat different than the depression that we see in other people who don't have Parkinson's, who are their age. We do not believe that depression is related to the medications that we use in treating Parkinson's disease. And people had talked about depression as being part of Parkinson's disease for many, many decades. And people would argue as to whether depression was intrinsic to the disease, that is the result of changes in the brain that cause depression on a physiological basis, or whether it was what we call a reactive depression, that when you have setbacks in life and things aren't going the way you had intended and you can't do or accomplish the things that you had planned, that you would be depressed as well. And the answer to the question, I think, it really is that it's both. That some people are depressed because they have Parkinson's. We see increased depression in people who are developing Parkinson's but haven't developed it yet. They first develop depression, and then later on they start to develop the symptoms of Parkinson's disease. We treat them with the same drugs as we use for treating depression in people who don't have Parkinson's disease. Apathy is another problem. Let me just say, well, let me go back to this. Apathy is a change in personality where people lose interest. They become apathetic. And unlike depression, where people typically feel sad or irritable, people who are apathetic really have a reduction in emotional content. They don't feel happy, but they also don't feel sad. And unlike the people with depression who are often feeling frustrated and they're angry because they can't do the things they want to do because of their Parkinson's disease, they don't get the same pleasure out of life because they had to give up things that they enjoyed doing as hobbies, perhaps, or sports, or their communication skills have deteriorated so they can't interact with people the way they did. And they are angry and irritable as a result of that. People who are apathetic simply just kind of shrug their shoulders and don't care very much. And so the spark in their personality, their motivation for doing things becomes much less. So there's a change in personality that occurs as a result of this. So when people start to become apathetic, they may not, say, care what is being shown on television. And then if they become more apathetic, they may not care whether the television is even on or off. They're content doing nothing. And what I always point out to families when this happens, because people grieve for the loss of the personality of their loved one, is that usually it's the family that's suffering a lot more than the patient. That although apathy is certainly a big problem for people with Parkinson's disease, it tends to be a lot more painful for the family and caregivers than it actually is for the patient, him or herself. And it occurs in both men and women, of course. People with depression sometimes become apathetic as well, so you may be dealing with an issue where a person is both apathetic and depressed. The problem with apathy for a treating physician is that we don't have medications that have been shown to help that. We have medications that improve depression, and depression should be treated. We don't have medications to improve apathy. I will frequently use antidepressants to treat the apathy because I'm always concerned that I'm misdiagnosing apathy when it really is depression, or the person really has an underlying depression causing apathy. But apathy is a separate problem than depression in people with Parkinson's disease. And it's associated, as I said, with a decrease in motivation. And there are a couple more problems that I need to just mention briefly. The compulsive behaviors. So that is a very important problem because that is iatrogenic. That is a consequence of the use of dopamine agonists. Those are drugs that have a chemical activity similar to dopamine. And the major ones, actually the only ones available in the United States now, are rotigotine, which is the Nuclear patch, pramipexole, which is Mirapax, and ropinirole, which is Requip, and apomorphine, which is Apokyn, and the new drug, I forgot the name of it, which is also apican that grows on in the mucous membranes of the mouth. And about 10 to 15% of people on these drugs, usually not at the beginning when they first start the drug. So it's usually something that develops after they've been on the drug for a year or more. And all of a sudden, they start engaging in compulsive behaviors, things like gambling, things like playing computer games too much, becoming much more interested in sex than they used to. And as these develop, they just feel that this is a normal activity, that they don't understand why they didn't used to like gambling so much, or why they didn't used to like knitting so much. And will often, not always, but often, they will behave as if they were addicts, like the interview with the man who was gambling too much. They minimize the problems that they're causing. They say it's not really a problem, I can control it, just like a drug addict might do, but they don't control it. And that's not true for everybody. Some people will recognize they have a problem, and then they will be agreeable to changing medications. People who have a real problem and deny that it's a problem often will not talk about this honestly. So whenever I put a patient on the drug, I ask to try to talk to a caregiver or spouse to keep an eye on the person to make sure that this isn't happening and that they're minimizing it. Fatigue. I have to say a few words about fatigue because fatigue is such a common problem in Parkinson's disease that patients often don't complain about it. So in studies that have been done, 1/3 of patients consider fatigue their single worst problem in Parkinson's, worse than constipation, worse than tremor, worse than slowness, worse than speech problems, in general. And about half of patients will rate fatigue among their 3 worst symptoms. So fatigue is a very common problem in Parkinson's, and we don't have any good trials showing that we can treat it. I think that stimulants are helpful for some patients, but the data to support that is almost non-existent. We have very few treatments for that. And fatigue occurs a bit more in people who are depressed, but it also is a problem for people who are not depressed. And it can, as I said, can be an overwhelming problem in people with Parkinson's disease. And it interestingly does not correlate with the severity of the motor symptoms. So there are people who have severe impairment because of Parkinson's and have trouble moving and trouble walking, and they're not fatigued, and other people who will look normal to most people when they're taking their medication who suffer from debilitating fatigue and won't engage in activities because it's too hard for them. They won't exercise because it's too difficult for them. When they do exercise, they fatigue easily and stop, and it is long-lasting, unfortunately. So this, I'll close very shortly. So this is an email I received after I gave a talk on fatigue. I'm a 74-year-old man. I've had Parkinson's 3 years. I can live with the Parkinson's, not great, but livable, but the fatigue is unbearable. As all my life, I was full of Superman energy. Now I'm only good for about an hour or so at a time, and between the lightheadedness and the fatigue, I'm wasted. I take 1.5 pills of carbidopa levodopa 3 times a day, 200 milligrams of Provigil, which is a drug to keep people awake, and a bunch of pills like NADH. I exercise as best I can and follow eating rules. I've been told to go see a shrink as if this was a psychiatric problem and start on antidepressants. I don't think I'm depressed. I'm retired. No life or things to stress me out. So I've been told fatigue is one of the 3 major problems of having Parkinson's. Most of the time I'm horizontal. I was told you gave a talk on this problem. So I did give a talk on the problem, but unfortunately we don't have proven therapy for this. But as I said, I think stimulants may be helpful, and of course encouraging exercise also. Anxiety I mentioned, and I just want to close on sleep disorders. People with Parkinson's have a lot of problems with sleep. Some of them are what other people their age have, which is bladder control problems. So because of prostate problems or current urinary tract infections causing some harm to the urinary tract in women, older people are often up 2, 3, 4 times a night to urinate, And because of the motor dysfunction, it's hard to get out of bed, then it's hard to get back into bed, then it's hard to get into a comfortable position, or the tremor in your hand may be waking you up because it's scratching against the pillow. So falling asleep and staying asleep are big problems. And then people with Parkinson's disease have a problem that's almost unique. It's not quite unique, but almost unique. And interestingly enough, has been a problem in Parkinson's disease since Parkinson's disease developed, but it was only recognized in 1986, which is really remarkable to me, at least since I practiced during that period, and I certainly didn't recognize it. REM sleep behavior disorder. REM is REM for rapid eye movement sleep, which is dream sleep. And during dream sleep, people are supposed to be paralyzed, except for their eye movements. Their eyes are darting back and forth as if they're following the action in the dream. And they're breathing, of course, so they don't die when they have a dream. So outside of that, your muscles are supposed to be paralyzed. And during dreams of vigorous physical activity, usually violent dreams, people will act out their dreams, and it's typically men. So they will punch, they will kick, they may jump out of bed because they're being chased in their dream, and they can either harm their bedmate or harm themselves. They might punch the furniture, they might kick something, or jump out of bed and hit their head against some furniture, which happens from time to time. For those of you who are interested in seeing what this looks like, you can look on YouTube. There are examples of people who have REM sleep behavior disorder, and most people who have REM sleep behavior, most middle-aged or older people who have REM sleep behavior disorder actually have Parkinson's disease. And it can be the presenting feature occurring as long as 20 years before the Parkinson's disease emerges. It's a treatable condition and can be recognized. There are a number of other sleep disorders that also may occur, but REM sleep behavior disorder is probably the most common. Sleepwalking, certainly sleep talking is more common. A lot of people with Parkinson's disease will talk in their sleep. For those of you who do it, you can just be reassured. I've never heard that anybody ever revealed secrets, but sometimes people will have somewhat different personalities in sleep and will curse at night when they're asleep, but never do that during the day. I had a patient who sang Italian arias while he was asleep, but that was unusual. So I will close there. There are other behavior problems, and undoubtedly other problems that we will discover in the future. And I will now be happy to try to answer any questions in the next 10 minutes.
Great.
Thank you for your.
Thank you, Dr. Friedman. So people liked your distinctions between the intrinsic and iatrogenic, and there were a couple questions about that. Someone said they read an article recently that apathy and impulse control were opposite sides of the same coin, but on your slide, you had them in the different columns. Do you disagree, or am I missing something? Was the question.
Well, no, you're not disagreeing that the impulse control problems occur as an iatrogenic side effect. Apathy is part of Parkinson's disease, and the question is whether the syndrome of apathy, being apathetic, not interested or motivated, is on a continuum with impulse control. And actually, while one would think that impulse control is a person who has so much motivation they can't control it, and apathy is a syndrome where people have very little motivation, so there's nothing much to control, that you can think of them as being polar opposites. But actually, there's a paper that either just was published or is about to be published, because I had seen it before it was published, indicating that actually there's some overlap, that some people who are apathetic may still have some type of compulsive behaviors. But I think in general, it's true that they are polar opposites in the sense that they're on a continuum. It's like somebody who sleeps a little too much, or somebody who doesn't sleep compared to somebody who sleeps too much. The continuum is sleep, and some people have too little of it, and some people have too much of it.
Okay, very good. Thank you. Kind of related. Susan asked if you could describe punding.
Punding is a disorder that was first described in people who were amphetamine addicts in Sweden, I believe. And the Swedish addicts use this term punding, which evidently means blockhead, to describe these people who were serious addicts. They used a lot of the drug, and they would start doing something over and over again in a compulsive manner that was totally senseless. And they typically would take things apart and put them back together. And they would spend hours just taking things apart and putting them back together. And it was described for the first time in Parkinson's disease and thought to be due to L-DOPA, when in fact it probably was due to a dopamine agonist, by me actually. And what I described was a group of patients who did these peculiar things. One person complained to me that he tallied figures over and over and over again. He was an accountant, and he would add up some figures, and those in the days, of course, before computers, so he actually tallied them up on an adding machine. And he would do it, and then he would do it again and again and again and again. Even though he always got the same answer, he couldn't stop doing that. I had a woman who couldn't stop reading cans in the supermarket. And so as soon as she encountered her first can, she was stuck because she had to read the label. And she would keep reading the label until she was forcibly taken away. Or a patient who couldn't stop trimming a bush in her yard. And she slowly whittled away, even through the winter, it slowly whittled away. So these are people who had compulsive, rather senseless behavior. Unlike, for example, gambling, which involves a lot of, potentially thinking, planning. You have to get to a place where you can gamble. You may do it on your computer, but you still have to do that. You don't necessarily play the same game over and over again, although among gamblers, I'm told that usually playing the slot machines is the one people favor more than others. So punding has to do with a single senseless act that's repeated excessively, whereas the other behaviors we think are a bit more complex.
Okay, thank you. It resonated with someone. They said that they do play the same game on the phone over and over, but they're not on a dopamine agonist, just on Rytary, carbidopa, levodopa. So still something to bring up with their doctor, right?
Yes.
Absolutely.
Well, if it bothers them, if it bothers them or the people around them, people who do these things often minimize it, so it doesn't bother them. But it may bother other people in the family because they won't come to dinner, they won't go to bed at night, they won't interact with guests. It can interfere with life. It really depends on the impact this has on their life.
And for care partners, spouses, family members, this might be outside of your realm, but how do you advise that they deal with these behaviors and deal with some of these compulsions and react to them?
Oh, I think the most important thing is to bring it up to the doctor and be honest about it with the patient as well, because it really can be devastating. I mean, that man lost, who I interviewed, lost his retirement. I've had other patients who had similar problems before this was recognized as a problem. So I wasn't aware that there was a link between the medications I gave him and this behavior. And I've been an expert witness in a legal case where a man was treated for his Parkinson's disease, lost all his money and he ruined his wife's business. And she went out of business and she sued him, and they sued the doctors for treating him. So it has to be brought to the attention. So, for example, patients who have this problem should be advised, if at all possible, for a family member to come with them, because you can talk to a patient and the patient will say, no, it's not a problem. I really cut back. I'm only gambling $10 a week and I can afford that without a problem. And then the spouse says, he lost $1,000 last week. So you need to get the whole history, and it really needs to be brought up to the doctor, because this is an iatrogenic problem. This is a problem that would be the same as, if I gave a drug and the person turned yellow from jaundice as a result of the drug. You want to know about it. You don't want to wait 6 months for the next visit, or 4 months, whenever it's going to be for the next visit. You have to do something about it, and it has to be explained in the context of, this is a medication side effect. This is not moral weakness. You're not being blamed for doing something bad because you're a bad person. This is a problem with the drug, as a side effect of the drug. Just like if I gave you a drug and you had a rash, you wouldn't say it was your fault. You would try to do something about it. But the person has to be willing to acknowledge that what they're doing is causing harm. And that's the big problem. Just like, drug addicts will usually know they're doing harm, but they can't overcome their craving. And in this case, very often people don't recognize that they are doing harm, in fact. On the other hand, I had a patient not long ago who was having a sexual problem, hypersexual, and it really bothered him a lot. I think he thought that he was going to have a problem, with his wife because of his sexual urges. And, he called me and said, I have this problem. And so we altered his medication. So it's important, for example, when I start a patient on this drug, I always tell them about this problem. I say it occurs in, 10 to 15% of patients, but you may not be willing to acknowledge the problem. Your wife or your husband has to know that you're taking the drug. This is a potential side effect. It'd be helpful if they came to the office. Of course, I always want a caregiver to come to the office because they see things differently often than the patient. But for these drugs, I always want other people to be involved so that we can nip it in the bud when it's much easier to take care of. And also, for example, in this case, the patient could, when I ask him about it each time, then he knows when it does start to happen, he says, oh, this is what Friedman was asking me about. And people, when I first bring it up, people say, oh, I'm going to gamble. I never gamble. And they think it's humorous. When it happens to you, it's not funny. And the same thing with hallucinations. I often, not always, but often ask about hallucinations. And then when the hallucinations do occur, then again, it's, oh, this is what Friedman told me about. They don't just go to the emergency room. They don't say, gee, I'm going crazy. I won't tell anybody, which is a common response for people with Parkinson's disease. But because it's been brought up and talked about, then they say, oh, this is the side effect that he warned me about. Makes it much easier to deal with.
Absolutely. And someone commented along those same lines that your differentiation between the schizophrenic hallucinations and Parkinson's were actually very reassuring, and it helps to know what it might look like. And so when it does, if it does happen, people can have that little that preview. So.
Well, that's the important thing about talking about these. Even if there are problems that we can't even treat, just recognizing that they're part of the Parkinson's disease, that it's not a moral failing to be fatigued. You're not going crazy because you're seeing little kids playing cards in your yard. You become an anxious person at the age of 60 when you weren't anxious before. It's not because there's something. There is something wrong with you. You have Parkinson's disease, but it's part of this disorder. It's not that you're becoming, crazy in any way.
Yeah, and to talk about it with your family, with your care team. Absolutely. Well, we have run out of time. Thank you all for your excellent questions. I think we always use the questions that we don't get to spark future topics and discussions. People were interested in learning more about dementia and Parkinson's, microdosing and psychedelic research, all kinds of things. So we have taken a note of that, and we could talk to Dr. Friedman for hours and hours, but he's a busy man, has things to do. So thankful for him to share his time and his expertise. And Dr. Friedman, we always close showing our gratitude with a goodbye wave. So if you scan through, it's always nice to see all the smiles and faces of people tuning in from all across the country and the world too. So thank you all for tuning in, and thank you again, Dr. Friedman.
Okay. Thank you very much for the invitation. I appreciate it. Bye-bye.
Bye now.
Bye-bye.